Good morning, all of you. First of all, I hope you had some sleep. I'm still very tired this morning. I would like to thank the organizers for inviting me to this wonderful initiative. And I'm also pleased, I'm glad to see many of my students in the hall. I'm pleased to try to share the joy of knowledge with many of you. My talk this morning will try to review some key issues regarding the public health value of public and private partnership, and hopefully may provide some background as to why there is cautious optimism from many of us in the field. Yes, this is the outline of my talk. I'll be talking about what? I'll give you the background. Yes. Then we'll try to understand the public health value of public and private partnership. Then I'll try to focus on some HIV public health related PPP with regard to three, for the interest of time, I've tried to focus on three main case studies. First, I will see how PPP helped in the understanding on the management of STDs and STI, and I'll focus on some of my work funded by the GlaxoSmithKline here on Earth. I can assure you I own no shares in these companies. And secondly, I'll try to mention the role of PPP in strengthening labs in my capacity of head of labs and blood safety in the Cameroon Ministry of Health. I'll try to mention the role of PEPFAR, the African Society of Laboratory Medicine, and many others who've been part of this historic change in Cameroon. And then I'll focus on the work on access to medical products and essential technologies. I'll try to give you a flavor of the work we've been doing over here with Merck Mpoke in developing a CD4 assay in Cameroon. And finally, I'll see the contribution of PPP in taking the healthcare closer to the people. I was the pioneer of mobile health unit in Cameroon 15 years ago. Then we'll try to review the lessons learned. Then I'll pay tribute to the many people who have been part of my research work. Well, for many of us who live and work in Africa, there's no doubt that infectious diseases do compound on heavy health problems which threaten the health and survival of many Africans. PPP can be defined as a sort of government between government and companies. And this has gained importance in recent years. As I said earlier, I will focus my talk on three specific case issues: the Glaxo work, and then PPP will refer here to many global health initiatives, which can be of impressive magnitude. But it can also be a partnership of private companies and development. It can also be a business relation of a public sector, of a private sector with a public organization. That's the case of many of what we've done. It can also be the privatizations of some public health services. That is the case of many global fund projects which have been managed in many countries by private companies. Now, let's focus on some HIV-related public and private partnership with regard to health system strengthening in Africa. I'll try to reassure my friend Peter Gottfried, with whom I met at London School of Hygiene more than 20 years ago, that we'll be talking about some quality research work with African leads. So I try to reassure you, Peter. We've been around for some time looking at ways in curbing the spread of AIDS in Africa. Most of my work were really collaboration, public and private partnership with NGOs, international organizations, and many private companies. I think this is what I'm trying to describe today. Well, let's first focus on my first case study, that is the understanding of the biological interactions between STDs and HIV, mainly herpes and HIV, And this multi-center work was performed while I was in the London School of Hygiene and Tropical Medicine and funded by GSK. Well, epidemiological studies of HSV in Africa clearly demonstrated high rate and high sort of prevalence of herpes viruses, mainly in teenage years. You can see the work we perform in many African countries, more than 10 of them, and showing high prevalence and high genital shedding. That is the shedding of the virus within the genital tract. And this groundwork was based on Ron Gray's contribution, showing a sort of deadly synergy. That's clinical reactivation of HSV, enhancing HIV shedding, and an increased shedding in patients with symptomatic and asymptomatic shedding. So this leading to try to suggest that by the increased shedding of a herpes may increase HIV transmission dynamics. And against this background, we did with a couple of colleagues. First here in Bangui, the capital city of Central African Republic, looking at these biological interactions between herpes and HIV. And again, you'll see that we found in this population an increased shedding of herpes, increasing with age, and we'll see later in high prevalence, and increased shedding in women than in men. You can clearly see in this slide that in our population, this was true in Cameroon, this was true in Bangui, but here we're in Bangui, both the sort of prevalence and the shedding of herpes was increased compared to in HIV positive patients compared to HIV negative patients. The sort of prevalence and the shedding quite double, meaning leading us to think that herpes could play a role in HIV transmission. Again, when we try to focus on the population of patients dually shedders, we could see a sort of while focusing on this group of population, what we thought was a correlation between those who were dually shedders, a correlation between HIV load and herpes load, leading us to think at the time, this has been confirmed in recent years, that herpes really played a role in HIV transmission dynamics. And then I will just give you a little story about this. That's at the early stage, that is in 1993 at UNESCO, when we tried to send a publication to Lancet. They wrote to us to tell us that we didn't clearly believe the results. So we had to go to Seattle to confirm the work in that Scottish lab in Seattle, just to make sure that what we found as a correlation at the time was really true. And again, this was correlated with the work of Angela Ubasi in Tanzania, also showing an increase of prevalence of herpes with higher rate again in women and men. And again, I show you the work we did in different African cities, in Kisumu in Kenya, Yaoundé in Cameroon, Douala in Zambia, and Cotonou. Again, this interaction between herpes and HIV will not only happen within the female genital tract. We also, 3 years after, demonstrated that this correlation could also happen within the oral mucosa, and this work was done at Eastman Dental Institute at the University College London. And again, we also proved that we could have high titers of neutralizing antibodies in dually HIV and herpes shedders. Again, this was a sort of important finding, leading us to think that these neutralizing antibodies could have a role in HIV or herpes transmission. Now again, this is what we define later on as the biological interaction between herpes and HIV. Herpes may increase the local local increased inflammations, the mediation of cytokines, I would think that HIV as well, by enhancing the alteration of humoral cellular immunity, we thought here that this is a vicious cycle, a deadly synergy between these two viruses. Well, this work really led to a number of challenges and potential avenues on future research on HIV STDs in Africa. We were able to access the burden of the disease. We were able to evaluate the potential of an anti-herpetic treatment, acyclovir, valaciclovir, in reducing the shedding of herpes on HIV. And again, we were able to develop and test preventive interventions. And again, work on the safe and effective vaccines. The work is being carried on today in La Disquales lab in Seattle. Again, we've been sort of promoting the syndromic management of in patients dually infected by herpes and HIV. This is a work performed in the group of La Disquales lab as the lead factor. Now, I will try to review a bit quickly the role of PPP in strengthening public health services, especially in Cameroon, the role of PEPFAR, SLM, and many others within the building of our research labs. Yes, I'll just give you a quick result of this PPP work. Today we have a national public health laboratory at Mpoke under construction. This is a PEPFAR funding. We have today more than 600 labs. We came from scratch, from nothing, and today we have nearly 600 laboratories within the central region and district. Enroll for what is today the quality assurance system. We have around 600 labs actively participating in national proficiency testing. This didn't happen before. We have today 9 labs going through the standard audit for accreditation. So this is a great success for me, my capacity of head of labs for the country. And Cameroon, we have 7 trained ISLM auditors who also provide support to many other neighboring countries, Chad, CAR, DRC, and many others. So this is an achievement just happening within the past 2 years. So this is for us a very tremendous achievement. Now, let me talk about the recent work, what we've been doing during the past 18 months, trying to look at the contribution to equitable access to essential medical products and technologies. And again, we need to partner here with many private companies. I'll try to give you just the flavor of the work we've been doing recently. Well, first background, the WHO revised guidelines to scale up EIT really emphasize on the need of immunological assessment based on CD4 enumerations and HIV dot. That is one of the work that's a piece of work in which we've been involved recently. And previously, we did some evaluations in partnership with many colleagues. The team of Victoria here came straight to my laboratory to see what we could do with my mobile unit. And again, with other colleagues, clearly trying to make sure that those machines could perform well in our very difficult settings. And against this background, we also, Victoria, we look at the evaluation of a CD4 machine, which could really be useful in our mobile unit. And again, this is machine, well, we try to compare the Muse assay with a comparative device. We did both comparison with the BD, with others, the Guava, the BD, fast count, we say the fast caliber, and clearly showing that the Muse assay had really comparative results. Yes, we clearly have comparative data between the Muse, which is clearly a small tiny machine, less than 3 kilos, with the fast caliber and other comparative device. So, both in adults and pediatric samples, those are some adults results. You can see the perfect gating, you can see on my right, lymphocyte on the population, the CD4 population, what I like best in this machine is clearly the possibility to really have a wonderful gating and define my population. And again, you can see that here we have a low patient with low count. We could go even that's lower than 10 CD4 cells per microliters. This was very important. I'll show you. Again, this correlation is good for CD4 in absolute values and in percentage. We can also see the total lymphocyte counts, which has a strong correlation with a comparative device. Again, what's very important to us was to look at the staining patterns. This is very important in hematology to try to make sure that we are trying to define the set of population we want. You can see various values. A for adult, P for pediatrics patients, and our control. Clearly, the staining patterns was very nice. We could also have a sort of snapshot on very low values. 72. A snapshot on very low values, and again, the machine could perform even below the limit of 20 cells. The importance of this type of machine in our setting is clearly that in one small machine, we have one method for adult and pediatrics. The machine is very easy to use. I could train my technician for around an hour. I'm able to perform the test within 30 minutes. And since we work in batches of samples, I can perform a amount of samples within less than 2 hours, which is very important. I'm not really looking at other aspects, but clearly it is less hazardous, we have less disposals. So clearly this is the type of technology we clearly need in our settings. And clearly this machine, we really believe that it's really very good for CD4 and enumerations in our setting. And so that was the conclusion of Fact. Then I will just try to tell you how PPP has empowered us in the field with regard to taking the healthcare closer to the population. And you can see, well, just a couple of slides of the work we've been doing over the past 15 years, going to remote areas. And this work, again, is a typical example of PPP. This was funded by the pipeline Mpoke going from Cameroon to Chad. So we used the money to screen for STDs, STIs, try to equip our laboratories within the pipeline. So this is just clearly a good example of PPP. We get these buses to our remote villages, try to do STD screening, very free of charge again, because of the pipeline project. And this is a type of equipment we still believe that we should be in a position in the next future to try to do HIV load, herpes load, and all these other things in this type of machine. I think that the people are quite keen to have this type of services. Well, the lessons learned, this is very important. I think PPP will work well, there's no doubt, if we can be able to reconcile the philanthropy of business strategy of the private partner and against the systemic surplus of the public partner. PPP needs a clear policy and priority field. We shouldn't allow the private company, for instance, to come and tell us this is what we want. PPP requires really a sort of mutual understanding. We should know what are the needs of the public service and the private service. And even time-limited PPP can have a meaningful contribution. We have several examples of what we did with the Muse and with DSK. And again, successful PPPs can help define future research interventions. This is very important because now we had a couple of meetings over the last months. We are trying with Merck to see how with the Muse we can do both the CD4 innovations, we can do the HIV load, we can also do work on cystotomiasis, and also have a sort of malaria test within the single machine. This is clearly the work we have in progress. Well, before closing down this talk, I'm only a scientist, not a movie star. But here, those are really the movie stars. I'm only a scientist. Looking at this from a small angle. And clearly, I want to pay tribute to the many of my colleagues who believes in medical research and strongly believes that the best is yet to come. And many others mentioned also in this slide, who care to listen to the illnesses, who whisper the tales of many voices, particularly the women and children in many parts of Africa. My friends of the University of Yaoundé One and at the Ministry of Health, my friends of IDE, my many colleagues at Inter Montaigne, the Chantal Bias Research Foundations, thanks to an excellent collaboration and friendship with Victoria and many others in the center, the Hôpital La Cité Verte in Yaoundé, the London School of Hygiene and Tropical Medicine, where I spent 8 highly educational years at Philippe, Rosanna Killing, David Brown, Peter Piot, and many others. John G. Teal and John Kengerson at the CDC. I also have to mention David Birch, who's been so instrumental with my PEPFAR funding. I also want to pay tribute to my friend Suleiman Boub in Senegal, and finally to my many friends Jane, John, Philip, Kamal, and many others working at Merck. Well, I thought 30 years ago that it was about time for action. I thought, and I still believe that the time for rhetoric has clearly passed. Should we want to rise to the challenge, I believe that we should work in partners, public and private, in curbing, in remodeling a strategy, in curbing the spread of AIDS. And I believe that failure on either side to accept this simple truth will clearly harm the very vulnerable people we purport to help. Thank you for your attention.